All right, this is going to be the practical side to the lecture. So I'm going to show you different concentrations of drugs, how we actually use them, what are their indications, and then their maximum dosage. So this is more of a practical, clinical thing. The other stuff is all theoretical, but this is now what you begin to use it. So now we're trying to apply the knowledge. The first thing you want to do is you want to keep in your mind that you have two different choices, two different families you can pick from. You can pick from the amides or the esters. In anesthesia, most of us will pick up amides, okay, because of the allergic potential that you have with the esters. The other thing we like about the amides is they're very consistent in their action. They tend to have more rapid onset of activity, which is what we want, because remember, we're always trying to turn over rooms faster, moving cases along, so amides are kind of helpful for us. It's not like a dentist's office where they can inject the medication and go to the next patient, and then come back half an hour later and the person's blocked and they can move along. That's how they actually work. If you watch how a dentist works, he doesn't come in your room and talks to you, injects you, and then sits there, waits for 20 minutes. And it would be waste. So he goes walking around. We can't do that. We can't skip from one patient to the next. We had to stick with that one patient. Okay, so we want the rapid onset. The amides all have I's before the cane, so the drugs that you use are lidocaine, mepivacaine, and bupivacaine. Those are the major agents that we use. On the ester side of it, we do use these occasionally. Cocaine is used by the ENT surgeons. The way they actually use it is because of its vasoconstricting properties, and it's a very effective local anesthetic. Okay? The downside to it is, of course, it gets systemic, and it can cause some toxicity issues. The other ones that are used is chloroprocaine, and sometimes tetracaine is used in low frequency rates. So let's look at lidocaine first. Okay? Lidocaine comes in many different preparations, and we use them in different uses. When you use 1% lidocaine without epinephrine, you're usually using that as subcutaneous infiltration. Normally we will use 1.5% or higher because that gives you a much better density block. The nice thing about the 1% to 2% local anesthetics is that they have a pH around 6, so they're not as acidic. If you add a little bit of bicarb, you can normalize their pH very easily and without dropping them out of solution, and it causes a less amount of pain. The downside to it is that lidocaine is a nice vasodilator, and one of the bad things is when you inject it into tissue and then you put a bigger needle into it, you see a lot of bleeding after you're done. Okay? And one of the things that we have problems with epidurals is sometimes there'll be so much blood between the dressing that it's a nidus for infection, and sometimes people call us and say, the site's bleeding and it's not stopping. So one of the things I do is I combine my local anesthetic, usually 1.5% lidocaine with epi, with my 2% lidocaine, and basically use that in a 50-50 mix. That gives me the epi, which helps me vasoconstrict the tissue, and so you get less bleeding. And you have a little bit less pain with it because I don't use a straight 1.5% lidocaine with epi, which has a pH of 4. So the one with epi causes a lot more pain. So if you have to choose which one causes this discomfort, it's going to be the plain one without epinephrine. You can add bicarb with the epinephrine. The thing is, you've got to use it almost immediately because the epinephrine will begin to degrade. So you do want to use it pretty quick. Now, the way you pick up on anything that has epinephrine in it, it is always labeled red. Such a simple thing. So when you look at the actual different local anesthetics, pay attention to the color. The color for lidocaine usually is blue, but when you add the epinephrine, it converts it into a red color, a red banding around it. Okay? Now, local anesthetics like this have preservatives in them, so it is inappropriate to inject into the spinal fluid space. One of the risks of doing epidurals and caudals is that these medications are perfectly okay to use for caudals, but they're dangerous to use for spinals. So if you inadvertently get into a spinal fluid space and then you inject the medication into the spinal fluid space, the preservative may cause a problem. Okay? So you got to be careful with it. If you want to use a spinal dosage, I wish it came out better. It comes out better, I think, in your slides. is you'll see this is the typical spinal dosage, which is 5% lidocaine, which is 50 milligrams per cc. And you'll see it, it'll say on it, which you can't see on the board here, it says spinal use. Okay? It specifically tells you that it's for spinal. Always look before you inject anything into the spinal that it says preservative-free or for spinal use. You should never inject anything into the spinal fluid space unless you see that. Okay? Lidocaine is a workhorse of local anesthetics. Its onset is very rapid. It has a pKa that's more physiologic at 7.9. Its potency, unfortunately, is low, so if you don't inject enough of it, you will get breakthrough discomfort. And its duration of action is usually short, which is 30 to 45 minutes, depending on the site, and up to 60 minutes for a low-flow area like the subarachnoid space. The duration can be significantly prolonged with epinephrine because lidocaine is a very potent vasodilator. So adding epinephrine will basically prevent the medication from being absorbed into the vasculature and cause better concentrations. The downside to lidocaine is it will cause neurotoxicity at high enough concentrations. So it has a pretty good safety profile, but what happens a lot of times is you use lidocaine for a lot of things, and sometimes you get into trouble with it. Indications, it's a great topical, infiltrative nerve block, regional, epidural, and subarachnoid, but the subarachnoid must be preservative-free. Where we also use lidocaine in the old days, when I first started, we didn't have a lot of pacemaker potential, and there was always concern about somebody going to VTAC, VFib. We didn't have amiodarone. So we used to put people on lidocaine drips, continuous lidocaine drips. So it was part of the protocol of somebody who was having acute MI. That's going away because what they're finding out that people are having more of a risk of actually, if they do go into an arrhythmia, they don't come out of it. Okay? So the mortality may actually be increasing with it. So there's a trend basically to decrease its use in that situation. Where it is appropriate to use, if you're having repeated episodes of VTAC and VFib, it's still an appropriate drug to use. The preferable drug now is, of course, amiodarone, which is a better drug. But it's still used in areas where if you don't have a defibrillator readily available, which is, I can't understand why it would be that, but you would sometimes will use that for that situation. Okay? But that's pretty rare nowadays. The other thing you'll see is sometimes people use it for a liver function test with primary metabolite, which is monoethylene glycine xylidine, which is MEGX, has been used to assess hepatic function and predict morbidity and mortality related to complications of liver disease. Migraine headaches has also been used for, and they use intranasal injection of lidocaine. It's usually very effective if you have a single-sided migraine headache. You put it in the same size as a migraine headache, and what it does is it vasodilates the nasal area over here, and it shunts the blood away from the brain and then basically stops the headache. Pretty effective, actually, and it's almost immediate. And it's usually within 5 minutes, the symptoms go completely away. And these people have these terrible stabbing, very, very painful headaches, and the lidocaine for those people can be life-saving. It can alter the way they actually act. It's usually effective only for unilateral downs. The downside to lidocaine is that over time it will start causing damage to the nasal mucosa. So it's something you hopefully don't over abuse it and just use enough of it. This is the lidocaine that we use intracardiac. This is the 2%, which is 20 milligrams per cc. What you're looking at is 100 milligrams in 5 cc vial, and usually it's 1 to 1.5 milligrams per kilo is a normal dosing. Where you also see it is for seizure activity. It's effective in the treatment of seizures resistant to other drugs. Ventricular arrhythmias, such as fast sodium channel blocker, is very effective for ventricular arrhythmias for that reason. It's effective for serious ventricular arrhythmias, such as VTAC, VFib. But of course, in VFib, you should defibrillate that individual. Then consider using lidocaine. It's useful for treatment of also attack arrhythmias associated with DIG toxicity. Maximum doses. This is what I expect you to memorize again. Is people will ask you this. If you're using without epinephrine, I try to put the first one without epinephrine. You'll notice that without the epinephrine, the dosage is a lot lower. Okay. The normal dosage, the maximum dose of lidocaine is usually 4.5 milligrams per kilo. and the maximum total dose should not exceed 300 milligrams. Okay? So what you look at is use 3 of those cardiac syringes, don't exceed that, 300 milligrams. Okay? Individual maximum with epinephrine, okay, can go to much higher levels. You can use 7 milligrams per kilo, and you can go all the way up to 500 milligrams, but should not exceed that. The next local anesthetic is mepivacaine, which is one of my favorite drugs. I like mepivacaine, also named carbocaine, also called polocaine is the other name for it. I use it quite a bit with blocks because it acts synergistically with blocks. So when you do peripheral nerve blocks, when you add it to bupivacaine will last 6 to 8 hours normally, and mepivacaine normally only lasts 4 to 6 hours. But when you mix it with bupivacaine, it lasts 24 hours to 32 hours. It's pretty amazing. So the synergistic action has not been really elucidated why it happens, but it does work pretty efficiently for you. Sometimes people are worried about it because it works so long that now basically people are telling me just use bupivacaine so we don't get it going on beyond the first 24 hours, which is a concern. So I'm switching back to using straight bupivacaine. But if I want a long block, I mix this drug with my bupivacaine. The onset of mepivacaine is also rapid, which sets up the block very quickly, versus when I use the bupivacaine alone, it's slow. So if I want a rapid block, I use the mixture of bupivacaine and mepivacaine together to get the rapid onset from the mepivacaine. The potency is on the weaker side, and it's normally by itself, intermediate action is actually intermediate in duration, which is 4 to 6 hours. The preparation that usually comes in is 1% or 2%. I usually use 2%, which is when I mix it together with marcaine. I usually use a 0.5% marcaine, which is a pretty high dose. But when I mix it together with this drug, which is 2%, when you do a 50-50 mix, then what happens is the medication drops to its 1% solution, and the marcaine drops to 0.25. So it gives you what you really want. Most of the time we use 0.25% for actual regional blocks. So your peripheral nerve blocks. You can also use mepivacaine with epidural and call anesthesia. The thing is, it's not a good idea for spinal dosing because it may cause some neurotoxicity. So for that reason, I'm not a real fan of using mepivacaine in anybody's epidural because of that problem. There's other agents that are better. So where it might be helpful is that mepivacaine is one of the few exceptions in the sense that it does not cause any vasodilation. So it may be actually helpful in a patient with hypertension or cardiac disease because it causes its longer duration effect. It usually does not necessitate the use of vasoconstrictors. So you can use this agent fairly safely without having to add epinephrine to keep it working for a long period of time. The next agent, which is also an amide local anesthetic, is bupivacaine. Bupivacaine also goes by the name marcaine or sensorcaine. Both those are the same. It's a trade names. So I always go by the generic name. I always will test you only on the generic name. I don't care about the trade names. I only want you to know the generics. Because your certification exams and your board exams, your C exams, all go on generic names. They're never based on the trade names. If you look at bupivacaine, it has a very high protein binding, which increases the duration of action. Its potency is fairly high, and it's also its onset, though unfortunately, is slow. Okay? The preparations that it comes in will actually alter the degree of onset. The more concentrated solution, the more rapid it takes place. The old solution, which was a 0.75% solution, which is not really recommended anymore, was used for epidurals. It really set up very, very fast. The danger of it is if you got an intravascular, you kill the patient. Okay? So it's now almost exclusively used only for spinal use, which is what we use almost exclusively in our practice. Bupivacaine is very, very safe. It doesn't really have neurotoxicity associated with it, and it has a good prolonged effect of 3 to 4 hours. When you add epinephrine to it, it can last up to 6 to 8 hours, which is sometimes we need to when we're doing double knees or something like that. So it's a very effective agent. The lower concentrations can give you a differential block. If you look at the 0.125%, it's a 1.25 milligrams per cc. And then you go to 0.5, it's just 5 milligrams per cc. You can see the marcaine also comes in epinephrine mixed in it, usually 1 in 200,000. One of the things you've got to be aware of is many of these bupivacaines are fine for epidural use, and caudal use, but not really appropriate for spinal. The only one that's for spinal use is a 0.75% solution. That's the only one that's preservative-free. Almost all the other ones have preservative in them. Even if you inject it inadvertently into the spinal fluid space, bupivacaine has really not been known to cause anything severe like Cauda-Equina syndrome. It has caused some degree of transient neurological deficits, but it's never caused prolonged effects, which is kind of good. So the safety profile for bupivacaine is actually pretty good. The indications, you can use it as a long-acting anesthetic, which produces local or regional anesthesia, especially for surgical, dental, diagnostic, or obstetrical procedures. It's the preferred local anesthetic in OB because of safety and because it has a nice significant differential blockade. It provides prolonged sensory analgesia with less motor block than lidocaine or chloroprocaine. And when more rapid anesthesia is required, you can use things like chloroprocaine, which is preferred choice in that situation. We almost never use chloroprocaine here because we have other techniques. We add bicarb to our bupivacaine, which increases the onset, it decreases the onset time and gives you a much better effect. Prolonged anesthetic and analgesic properties of bupivacaine decrease the incidence and severity of post-surgical pain, which is part of the benefits of using it. And it tends to be less of a motor blocker, so these people will be pain-free and still moving their legs after surgery, but they'll still be comfortable. If you do infiltrative local anesthetics, the bupivacaine by itself is the longest acting one, and as a consequence, it's really a good treatment for chronic pain therapies like acute active herpes zoster infections, and that's what it's been used for. Now, bupivacaine, when injected into the muscle, is myonecrotic. You know what that means? That means the muscle melts. Okay? And you guys are like, why would that be good? You know, that doesn't sound good. Well, bupivacaine is a drug of choice when you're doing what's called point blocks, okay, or trigger point blocks. People that have certain kinds of muscle diseases will cause a small area of their muscle to become damaged, and then the spindle fiber that's inside of it becomes hyperreactive and causes the muscle in that area to bundle up and causes severe pain because it's constantly in spasm. You know this is because when you walk up to these patients and you touch them in that area, they'll go right through the roof. Okay? Now, what you actually do is to take care of this problem is you take ethylene glycol, which is a spray, and you spray the skin first to take away some of the sensitivity. And then you take 4 to 5 cc's of bupivacaine, usually high concentrations, which is more myonecrotic, using 0.5% bupivacaine. You put the needle right in the middle of the area and then inject it. What happens is if you look at the pathology of it, if you took a biopsy of it, within 24 hours the muscle, this literally melts away. Okay? And what will happen is a new muscle will reform in that area that hopefully will be normal with a normal spindle, and then the pain goes away. What's interesting, though, is that people that have this kind of problem, it tends to be repetitive. If they injure themselves again, they have something wrong in their genetics that they are more predisposed to having this muscle bundling effect that they see. Okay? But it really can make a difference if you... I've actually taken somebody which had crippling back discomfort, and after we did 4 or 5 trigger point injections, and about 6 weeks later, that person had 0 pain and was back to being normal. And every time they had pain, which was usually about every 7 or 8 months, they would come back and they get 1 single trigger point injection, and they were back and ready to go again. So they were just more prone to it. Now you can actually help somebody if you're married to somebody with this kind of problem, is that you have to give them back massages, and you have to rub hard to break up. And massage therapy is just as effective as a trigger point injection if you get it early. So when people tell you that massage therapy doesn't work, that's not true. It does work. You can actually break up the actual muscle spindle by your hands, and if you get to be a good masseuse, you can actually physically feel the muscle that's damaged. And as you rub it out, the person will not be happy with you, trust me. Okay, but when you rub it out, the person afterwards feels better, and it can make a significant difference in their overall life and being comfortable. When compared with other local anesthetics that provide similar onset and spread, it's a significant advantage of bupivacaine over chloroprocaine. Etidicaine, lidocaine, or tetracaine is a longer duration of action, which is what makes it really beneficial. Differences among these agents is the duration and block is dependent on the concentration of the anesthetic, and bupivacaine is fairly safe as long as you utilize it carefully. In other words, you don't inject this stuff freely without checking, aspirating every 5 cc's. You've got to be careful with this stuff. Important note about bupivacaine is do not use a 0.75% solution for epidurals. It is very unsafe. Okay? I personally had an experience when I was a resident when one of my fellow residents was in a rush. He'd read about that bupivacaine was great, 0.75%. It set up really great. He grabbed it off what we had, our cupboard, pulled it off, and then took it, and then he aspirated back one time, and then he gave the whole 20 cc's without re-aspirating back. And unfortunately for him, the woman immediately coded. She went asystolic because what happened was the bupivacaine got intravascular. It was pretty tragic at the time. We thought we were going to lose a woman. The first thing you do if you have a woman arrest on you that has a baby, you immediately cut her. So we actually extracted the baby by the obstetrician in the room. We didn't even go to the OR. I just splashed her and cut her. And at that point, once the surgeon had delivered the baby and he squeezed on the uterus, then we continued doing CPR for an hour and a half. We actually put in an arterial line, monitored, and we just kept doing CPR. At around 50 minutes into it, we started getting 1 beat per minute. And about an hour, we were at 6 beats. Not very much. And eventually, about an hour and 15 minutes, we were about 40 beats per minute. And then an hour and a half, she woke up. Okay, it was rather amazing. She was actually waking up during our CPR. That's really not kind of good. She did remember that. But we were doing very effective CPR, and there was 4 big guys all pushing as hard as they could. We broke several ribs. The good thing is she eventually walked out of the hospital okay with the baby, had a few ribs fractured, but she did say to her, she put up on her actual room the next day. She was kind of funny about it. She actually made her husband do an epidural, and it put a little cross on it. No, 0.75%. So she put it up on her door. It's like, wow. It's like some people they're tough enough they make jokes about stuff. But she actually remembered parts of it and was pretty okay with it. She said we kept yelling at her not to leave, and that's the reason that she didn't leave. We were pretty stressed out, to say the least. The other thing where you can get in trouble is if you do a paracervical block. It's so near to the head of the baby that you inject it indirectly into the brain of the baby, you kill the baby. So 0.75% is contraindicated for paracervical blocks completely as well. Bupivacaine, the maximum doses, when you give it without epinephrine, is less than 175 milligrams, which is it's a lot. It's still a lot of volume. Okay, if I'm using 0.5% bupivacaine, that's 5 milligrams per cc. So 5 goes into 175 how many times? 30-something, right? Okay, so it's 3 times 5 is 15, so it's 25. So it's like 35 cc's. So you can give 35 cc's to an individual without epinephrine. If, on the other hand, if you do it with epinephrine, you're up to 225 milligrams. Okay, so you have to take that into consideration, and that's how you figure it out. What I'm going to ask you on the test is one of those questions. Not this one, but the next one after that. I'll ask you, okay, when the surgeon asks you how much should he inject, the first thing you got to ask is what's the concentration. When you get the concentration, if you say it's 0.25, then that's 2.5 milligrams per cc. Then you need to know what the toxic range is. In this case, it's 225. Okay, then you basically can give 100 cc's of that stuff. Okay, that's a lot. Okay, and not be in too much trouble. Okay, the dose should not be repeated at intervals less than 3 hours because it will accumulate, and maximal dose is 400 milligrams in 24 hours should not be exceeded. Okay, so you got to be a little bit careful. If 0.5% without epinephrine is used in obstetrics for continuous infusions, you should limit it to a maximum total dose of 320 milligrams. Next drug, ropivacaine, is also a amide. Its onset is very similar to bupivacaine, so it has a little bit faster onset, so it's a moderate onset. Potency is high, though, just like bupivacaine. It's the same molecule, except they added another carbon group over here. And the duration of action is very long, but it's a little bit shorter duration than bupivacaine. The problem with it is the drug causes the motor blocks a little bit less intense, and the sensory block is similar. There's a little bit less toxicity, especially less propensity to cardiotoxicity, and there's less central nervous system effects. Ropivacaine is also called Naropin, or that's what I call it, Naropin. Pretty good drug. What's being used for mostly is for intense postoperative pain, because you don't want intense motor blockade. This drug does not have good motor blockade. So it's great for use for long-term treatments of pain, and they're using it for continuous blocks on patients, which is fine, because it's if it gets intravascular inadvertently, you then have less cardiac and CNS toxicity with it. So it's really used for postoperative pain, and some places are using it for obstetrical pain. We don't use it here because it's so expensive. Ropivacaine is 20 times more expensive than bupivacaine. I'm sure there's that much difference. We'll wait till it goes out of, it goes and becomes generic, and maybe it'll become cheaper then. Etidicaine is another local anesthetic. It's a long-acting injectable lidocaine derivative, so it looks very similar to lidocaine. It's great for infiltrative, regional anesthesia, and epidural is very limited and not to be used for spinals because it does cause neurotoxicity. The pKa of it is 7.9, very similar to lidocaine. It's a little bit slightly more rapid, which is 2 to 5 minutes. The duration of action is long, which is a little bit different than lidocaine, which has a short duration of action. And the potency on it is fairly high. It's approximately equal to the potency to bupivacaine. So etidicaine has some benefits just by changing the structure. Still has a rapid onset, but a longer duration and a little bit higher potency. The problem with this drug, unfortunately, is that it's not been very safe for spinal use, and that really limits its use in the epidural space. So you can use it infiltrating just fine. These are some of the extra doses that come with it. Etidicaine is not for use for spinal anesthesia. Again, can be used epidural, but it's inferior to bupivacaine. That's why we don't use it, because it causes less sensory nerve blockade, but with a greater motor blockade, which is not what you want. You want more sensory than motor. So anything that goes more to motor is not good. So for this reason, this drug has not been used really extensively. It has really poor analgesic activity compared to bupivacaine, so that's really, it's never going to replace that drug. It's going to be just something that's interesting to talk about, something that's not really useful. Etidicaine maximum doses with epinephrine. Without epinephrine, it's only 300 milligrams, and with epinephrine, it comes in up to 400 milligrams. Prilocaine is the next local amide local anesthetic. It tends to be mostly used as a topical and infiltrative anesthetic. It's never used as an epidural or spinal. It can be used intravenous, but I'm really hesitant to use that, even though the book reports that it's been safe in that respect. I would never use prilocaine. I always use lidocaine for my intravenous regional anesthetics, which is the beer blocks, because I don't want anything to cause methemoglobinemia, which is what this will do, and it's dose dependent. The onset's very rapid, which is kind of nice, but its potency is low, and it's actually considered a very short duration of action. Prilocaine is a part of EMLA cream, and the way EMLA is applied is you put it to the skin, and then you put a tegaderm over it. It works very well. It's got EMLA is a combination of lidocaine and prilocaine. Each is a 2.5% solution. Sometimes EMLA comes in 5% solutions, which means it's 5% lidocaine and 5% prilocaine. When you get prilocaine, even in this format, you still can get methemoglobinemia if you cover enough surface area, which is the example I gave you before. So it's something you don't want to use this stuff for. Okay? You just want to cover it just enough to get your IV started, and that's it. Okay? It's not appropriate to take a bath in it. Methemoglobin with prilocaine is a formation of methemoglobin from otoluene, which is a normal metabolite, which is hepatically derived. It's dose-related with detectable methemoglobin. Serum concentrations usually appear following prilocaine doses of exceeding 8 milligrams per kilo or greater. The maximum dose you should ever use is 10 milligrams or 400 milligrams, or 10 milliliters or 400 milligrams of 4% prilocaine solution within a 2-hour period of time. So now we're going into the esters. The first one I'm going to talk about is chloroprocaine, followed by procaine, then followed by tetracaine. Chloroprocaine is procaine with an added chloride component to it. Because of that, it has very rapid onset, not so much because of its pKa value. It's one of the exceptions. The reason that chloroprocaine sets up so fast is its concentration. It usually comes in 3% concentration when you inject it, so that has such a high value of local anesthetic that it's actually able to push into the cell very effectively. Its potency is low, and its duration of action of chloroprocaine is actually short, so it lasts anywhere between 30 to 60 minutes. Chloroprocaine has a low potential for hepatic systemic toxicity because it's so rapidly metabolized. One of its clear indications for use is for acute C-sections. We used to use a Nesicaine, 3% Nesicaine, which is chloroprocaine, right before we went for C-sections, and has very, very rapid onset, and it would have very good density, and the woman would be very comfortable doing that procedure. The downside to it is that chloroprocaine had a preservative in it that caused almost 80% of women that got dosed with it back discomfort. They took away that preservative, and now the new drugs don't have that problem. But one of the concerns still is that if you get an intraspinal injection, you can get into trouble with this drug. It may cause transient neurological symptoms, so for that reason, it's not recommended as spinal. It's an appropriate anesthetic for outpatient surgery because it's short-acting. It reports the sensory and motor deficits following inadvertent subarachnoid, which I was telling you about, and so it makes it less desirable than other local anesthetics. Usually the dosing that you use is 3% chloroprocaine to get that rapid onset effect. Chloroprocaine's maximum doses. If you do without epi, it's 11 milligrams per kilo, not to exceed a maximum dose of 800 milligrams. You can see the value goes really up. The reason that it has to be so high and be still safe is because that drug comes in 3% solution, so that's 30 milligrams per cc. That's a lot of medication in 1 cc. Okay? So 30 milligrams goes into 800. Let's see, take 0, and 83. So it's about 39, 29, almost 30 cc's is what you can use. So it's not a lot of medication that you can use. So it's not really appropriate for infiltrative anesthetics like lidocaine is. Chloroprocaine is also used for eye surgery, which is also very effective. You don't need a large volume to inject there. If you add epinephrine, you're up to 1,000 milligrams or 14 milligrams per kilo as your maximal dose. Really try to keep your lowered effective dose as much as you can. Patients can respond oddly sometimes, so even though you think those values are absolutely valid, somebody has low protein concentration in their blood, elderly patients, little kids, or people that are acutely ill are much more prone to get chloroprocaine toxicity. Procaine is the next drug, which is also known as Novocaine. This is what most of our dentists use in this area, as well as most places in the United States, because it's so cheap. So Novocaine is by far the #1 drug that's used by dentists. Its onset is actually very slow. It takes about 15 to 20 minutes for the local anesthetic to kick in. And its potency is low, which makes it safe. And its duration of action is short, which is about an hour to 2 hours. There's really low potential for systemic toxicity. The problem with it is that it causes an allergic reaction due to the formation of para-aminobenzoic acid by rapid hydrolysis. Indications is for infiltrative anesthesia, so it's ideal for dentists, and peripheral nerve blocks sometimes is used, but it really limits it due to this allergic potential. So when somebody comes in and says that they're allergic to local anesthetic, it could be that it's due to an ester, so I wouldn't worry about it. But the other reason that people say that they're allergic is they got injected epinephrine. Epinephrine makes you have that anxiety and tachycardia. I was in a dentist's office a few years ago, and they injected the local anesthetic in my jaw, and I said, "You need to stop." And he goes, "What's happening?" He says, I'm getting tachycardia, and you injected the epinephrine into my bloodstream. He said, no, you're allergic. I said, no, I'm not allergic. It's not an allergic reaction. This is just epinephrine. I know the difference. Okay? And my blood pressure was, my pulse went from 70 to 140. It was kind of exciting. And it made me aware. I could actually see the outside world, and I could see the little palm leaves were moving, and I was actually paying attention to details. It's pretty cool. That's not an allergic reaction. The allergic reaction is profound hypotension, shock. That's very serious. So the epinephrine is what most people confuse And the dentists, for some reason, are almost taught immediately to tell them that the person's allergic when they inject inadvertently, into your bloodstream. Which is, I didn't worry about it. I said, just take the needle out for a second, redirect, and then we can do it again. He looked at me kind of funny and says, yeah, that's right, I forgot you're an anesthesiologist. I said, yeah, go ahead. So, bad thing, bad genetics, bad teeth. So, got to keep working on them. Procaine's maximum doses is total dose of Procaine during one treatment should not exceed 1,000 milligrams. Procaine is similar to tetracaine. It's slightly different in the way its R groups are determined. But it does have a pretty good maximum dose of 1,000 milligrams, which is pretty good dosing. Tetracaine is the last one we're going to talk about. I only got one more slide after this. Tetracaine is almost effectively used as a surface anesthetic, so it's really not used that much except for ophthalmologic procedures as well as airway procedures. The problem with tetracaine is sometimes it's also mixed in with benzocaine, so you got to be careful with it. It's effective in spinal anesthesia, which is what I've used it in the past for. It comes in a powdered form. I was looking for it online yesterday. I couldn't get a picture of it. But tetracaine, when it comes in your kit, it's in a lyophilized powder form. Okay, so if you look at it, it's in a powder inside a vial. So what you do is you break open the vial. If you want to make it isobaric, you can. What you do is you put the spinal in, and you draw up 2 cc's of spinal fluid, and then you mix it with your tetracaine. And now you've got your isobaric solution, which means it's the same baricity. So when you inject that medicine, it just sort of sticks right where it's at. Most of us will inject it with the normal saline that's associated with it, which is preservative-free, and that will make it hyperbaric, or it has a D5, normal saline in it, which will make it hyperbaric. And you can also make it as an isobaric solution, which is something I had to do the other day. So the only one that can actually allow you to do that is tetracaine. None of the other drugs come in powderized forms. So that allows you to change the actual solution that you're injecting it in. And if you give somebody hypobaric solution, the spinal goes up. It goes against gravity. If it's hyperbaric, it sinks with gravity. Okay, so if you have somebody, this is where we were doing it. We had a hemorrhoid surgery, and the guy was upside down, and the surgeon wanted me to do the spinal while the guy was already in jackknife position, which I'd done before. It's like I didn't think anything of it. But then I found out what a pain in the butt it was, because I'd forgotten that we don't have tetracaine like we used to have so readily available. So I had to go find it in pharmacy. We found like 3 of them in the whole hospital, pulled it back. Then I kept looking for what makes it a hypobaric solution, so it would stay in a sacral root area and away from going to the bottom of his head. Because if you inject a hyperbaric tetracaine, if you put him in the jackknife position, the person's butt's up in the air like this and their head's down. So the medication would go straight down and cause them to get a high spinal. Okay? So you give them the hypobaric solution and it goes up. It floats upwards and knocks out the sacral roots, and it's very effective. And the reason we were doing that was because the guy had extensive back and hip problems, and didn't want to be positioned after the fact. So we got it in. It actually worked really well, but tetracaine is the only way you can do that. Toxicity and slow onset of action limits the use of these agents, and that's what tetracaine will take at least 15 minutes to work. You have to be patient. The surgeon, of course, was running around and going like, why can't this thing set up fast enough? I said, you've got to be patient. I told him it's going to take 30 minutes to work, possibly. And it took exactly 22 minutes. So it's like, okay. So now this guy was comfortable. They did his hemorrhoid surgery, which took about 20 minutes. The actual time in the room took longer to set the spinal up than the actual thing. The duration of action is average. It's 4 to 6 hours, which is fairly long, but it does work pretty good. If it's used ophthalmologically, you usually use 0.5% solution. 1 to 2 drops may be instilled in the eyes. It's very effective. We use this sometimes for corneal abrasions. It works very effectively. The thing is, you don't want to send the patient with it home. Just because that person is comfortable, you don't let them have the tetracaine and take it home. Because what we'll have some of these people do is they'll just keep pouring the tetracaine in their eyes for the next 3 or 4 days, and instead of keeping the eye patch on, which is what they're supposed to do. If you keep the eye patch on, the corneal abrasion doesn't hurt you. It's when you open your eyes. So what these people want to do is they don't want to have an eye patch on them, so they take the tetracrine and they instill it in them. And what they end up doing is they get keratitis or they get severe corneal adverse effects. So you don't want to let them have it. Okay? So only if to get them out of the place, that's fine, but you tell them keep your eyes closed for the next 48 hours and the corneal abrasion will go away.